Your baby inside is telling you something, but maybe you're not listening to it. What if I tell you there is a simple painless test which can tell you whether your baby inside your abdomen in your body is doing well or not? Hello, I am Dr. Rajat. I am a gynecologist and I have used this non-stress test multiple times to know whether the baby is safe inside in the body or not, and to take critical decisions to prevent the mishaps from happening during the end of the pregnancy. In today's video, I'll tell you what is NST, when is NST done, how to interpret the results of NST, what to do if NST is not normal, and does an abnormal NST means that baby is abnormal, and lots of more. For this video till the end, I'll give you a bonus tip as to what are the common mistakes most of the females do when they come for a NST or a non-stress test. Hello, I am Dr. Rajat. I'm a practicing gynecologist and I've started watching our YouTube channel, The Fertility Gynecologist. Many females, when they are in the last months of pregnancy, they are often worried whether my baby is normal or not. They have got done ultrasound at about 24 weeks, the anomaly scan, 3D, 4D scan, absolutely everything is normal. But still there is a constant sense of fear whether the baby is normal or not, and that fear gets heightened especially during the last months, 8th and 9th month of pregnancy. That is more so if the female is of elderly age, the pregnancy has occurred after long years of conception, there is an IVF pregnancy, or there is the patient is having blood pressure. These things heighten her tension, and she wants to know whether her baby is normal or not. In those cases, we do something called as an antepartum fetal surveillance. Most of the females, they ask us, sir, why do you call every monthly, and during 8th month every 15 days, and during last month every 7 days? This is an antepartum fetal surveillance because certainly some mishaps can occur at any point of time, and if it is a constantly monitored surveillance is done to prevent the unfortunate events either in form of a decrease in the fetal growth or in form of an intrauterine fetal death to occur from happening, and that is why we do an antepartum fetal surveillance. And there are two most important components of fetal surveillance in this series. One is a non-stress test and another is a doppler. Doppler we will discuss in couple of videos in the next part of the series, but in today's video I'll discuss about non-stress test. So what is a non-stress test? Non-stress test means we want to find out how the baby reacts to the movement. You must have wondered or realized whenever we are doing any kind of movement exercise, our heart rate increases. So at that point of time, the body is under physical stress, and that is the basic premise of what they do in cardio. It is called as a treadmill echo, and in our obstetrics we do it as a contraction stress test. We stimulate the contraction, we give the baby a stress, and we see how the heart reacts to that thing. But no, I'm not talking about contraction stress test in today's video. I'm talking about we are not giving stress to the baby, and we just want to see how the baby's heart rate behaves over 20 minutes in response to movements. If the baby does not move in response to movement, that does not mean there is no acceleration of fetal heart rate in response to movement. That does not mean that there is an abnormality in the baby. That may mean that baby is getting some amount of less oxygen. So when do we do an NST? Or in other words, what are the indications of NST? We can do NST normally. Ideally, NST should be done in every patient. But because there are many patients, we have to do the triaging of those patients, and we have to decide when to do an NST. Any high-risk mother, if that mother is having diabetes, that mother is having hypertension, that mother is having systemic lupus erythematosus or antiphospholipid endothelin syndrome, or that female has undergone any IVF, that female is having chronic hypertension, that female is having renal or thyroid disease, or that female is having a age which is more. In our obstetrics, we call any female who is more than 35 of a high-risk female. That patient is obese. There can be a fetal related factors. If there is, we are suspecting the fetal growth restriction. If there are decreased fetal movements, if there are multiple pregnancies, then also we do an NST. The factors can be related to the pregnancy, the obstetrics. Last time the patients had a unfortunate event of abruptio placentae, or intrauterine fetal death, or severe preeclampsia, or fetal growth restriction, or there is a bad obstetric history, or there is a oligohydramnios in this pregnancy, or in the 12 week or 24 weeks of sonography, we see that there is a vasa previa, or there is a single umbilical artery. In those cases, we tend to do NST. Why is NST important to me? I am talking NST. NST basically tells me about the oxygenation level of the fetus. We all know without oxygen we cannot survive. So does our fetus, which is inside the womb. NST tells about the oxygenation level of the fetus. A reactive NST is always reassuring to the patients and to the female and to the doctor that everything is well inside. A non-reactive or an abnormal NST can make us to take the decisions relatively earlier to prevent the mishaps from happening. And it can also detect the early diagnosis of complications. So how the NST is done? Basically, we call the patient after having a decent meal, at least 1.5 hours after having a decent meal. We let the patient lie down. There are two probes which you will see in this photograph. There are two probes. One is a fetal probe and one is a toco probe. And the fetal probe is put on the site where the fetal heart rate is audible, and toco probe is placed on the lower part of the abdomen for the uterine contractions. And we give one instrument to the female to tell her whenever there is a fetal movement, you press this. So the basic premise, like I said, and we mostly ask the patient to lie down, but the ideal position is a semi-fowler position in which head is slightly up and the slightly patient is on a left lateral side. We basically just need a 15-degree tilt to prevent the aortocaval compression. So NST graph, like you can see in this photograph, it contains, there are four basic components of NST graph. One is a baseline fetal heart rate. If you see the chart paper, there are the blocks of 5, 120, 125, 130, 135, 140, 155, so on and so forth. So there is something called as a baseline fetal heart rate. It can be a low baseline fetal heart rate. If it is less than 110, we call it as bradycardia. If it is more than 150, 160, we call it as fetal tachycardia. And normal fetal heart rate is between 110 to 150 beats per minute. Tachycardia is usually if there is a maternal fever or if there is some maternal infection. It can be stress, it can be hypoxia. Bradycardia is usually due to cord compression, head compression, or fetal hypoxemia. There is less oxygen in the fetal blood. Then there is something called as a baseline fetal heart rate variability. It is not a straight line. It is always sawtooth appearance, sometimes increasing, sometimes decreasing. That fetal heart rate variability is very, very important. If it is absent, it definitely signifies that there is some problem. If it is a minimal, less than 5 beats per minute, it can be a normal 5 to 25 beats per minute, or it can be marked. It can be more than 25 beats per minute, but between 5 to 25 beats per minute, the fetal heart rate variability is normal. The fetal changes in fetal heart rate variability are again because of hypoxia, prematurity, fetals might be sleeping, or there might be mother might have taken some kind of narcotics or some kind of analgesics, opiate analgesics, by which the fetus is depressed, and there is a less variability. Then the most important component is acceleration. The fetal heart rate increases to about 10 to 15 beats per minute, and that duration of that acceleration is about 10 to 15 seconds. That acceleration is mostly because of the fetal movement or because of the uterine contraction. And the most worst aspect which we do not want to see is deceleration. So if this is the baseline, this is acceleration, this is deceleration. Now deceleration, there are 4 types of deceleration. It can be early deceleration, it can be mid deceleration, it can be late deceleration, or it can be variable deceleration. Early deceleration is usually because of the compression of the head of the baby. Whenever the head goes inside, it leads to the early deceleration, and whenever it is with uterine contraction, and whenever the contraction goes away, the deceleration becomes normal. The late deceleration which is significant. It basically signifies the placental abnormalities, decrease in the placental blood flow, and thereby decrease in the blood to the baby. And then there is something called as a variable deceleration. It is usually not related to the contraction. It is again variable in depth, in duration, and this is mostly because of the cord compression, which usually occurs either because of the cord around neck, or because of cord presentation, or because of the cord is compressed because of the less water or the oligohydramnios around the baby. And there is something called as a sinusoidal pattern, in which there are no bit-to-bit variability, no acceleration, deceleration, but there is a simple sine wave kind of thing that usually signifies fetal anemia that we see in vasa previa. So how do you see the results of an NST? There are 2 things. One is a reassuring NST or a normal NST. We always call it as a reassuring NST. A reassuring NST is usually in which there are at least 1 to 2 accelerations. There are no decelerations. There is a beat-to-beat variability in a 15 to 20 minute period. At least 2 accelerations with movement. This indicates that fetus is healthy. Fetus has got an intact cardiovascular, intact neurological, and an intact musculoskeletal system. And we do not need to do anything. We need to continue the pregnancy as it is going. There is something called as a non-reassuring NST. Mind you, it is not abnormal NST. The second report is non-reassuring NST, in which the baseline is somewhere between 100 to 110 beats per minute. Variability is less than 5 beats per minute for about half an hour. There are no accelerations with movement or no accelerations at all. There may be a variable deceleration or it may not be there. But mind you, the absence of acceleration does not mean that there is some problem with the baby. It just is telling us that we need to do certain more investigations, certain something else needs to be done to evaluate for the safety of the baby inside. Then there is a abnormal NST. Abnormal NST, again, the baseline fetal heart rate may be less than 110, or baseline fetal heart rate may be more than 170, 180. That means it can be tachycardia or it can be bradycardia. The fetal heart rate variability is less than 5 beats per minute for about 30 to 90 minutes. There are not any acceleration, and there are atypical variable deceleration, which are over the 50, duration is more than 50% of contractions. And sinusoidal pattern is also an abnormal NST result. Now, how to interpret the results of an NST? I have told you this is normal, this is reassuring, this is non-reassuring, and this is abnormal. So, does that mean, suppose a non-reassuring pattern comes to us or a abnormal pattern comes to us, do we take decisions at that point of time? Answer is no. NST has got many false positives. So, if there is an NST which is abnormal or a non-reassuring, we just do not immediately take that decision. There are 5 to 7 things which we can do. Patient may be on an empty stomach, or patient maybe have eaten a little while before. So we first of all order some sugary drinks or glucose to the mother. Baby may be sleeping. That is also the reason that the NST may not be normal. We take the NST in a left lateral position or a semi-fowler position. Or sometimes we can also give some IV fluids to the mother and then repeat the NST few hours later. We can also do something called as a VAST, vibroacoustic stimulation test. Baby might be sleeping, so we put some kind of an artificial noise or alarm over the abdomen of the mother for about 20 to 30 seconds to wake the baby up, or so that the baby makes some kind of movement. And we also do an ultrasound to see for the liquor of the baby. Now, I always tell my patients, if there is a placental abnormality means there would be decrease in the blood flow from the placenta to the umbilicus to the fetus. The umbilical artery blood flow goes to the fetal heart. From fetal heart, the blood flow goes to the fetal kidneys, and from fetal kidneys, whatever the urine comes out, it is a liquor around the baby. So if the liquor around the baby is less, that would suggest to us that there is some kind of a placental abnormality. The umbilical artery Doppler and the uteroplacental circulation we will discuss when we will do the video of Doppler. So in those cases, if NST is abnormal, we get an ultrasound Doppler done. If Doppler is normal and NST is normal, there is 100% chance that baby is absolutely fine. We can prolong the pregnancy as it is. If Doppler is normal but NST is non-reactive or a non-reassuring pattern, that does not mean that baby is not well. That means we have to do certain other investigations, or we have to repeat the NST, or we have to do some kind of things. However, this kind of deliveries, only 7% deliveries occur before term, mostly they occur on term. If both Doppler and NST is abnormal, that means there is some kind of a fetal jeopardy and we have to take the baby out. In about 50% cases, there is a chance that there may be problem. Now comes the interesting case. Doppler is abnormal, but NST is normal. That means we can still pull on this pregnancy for a few days more. And those few precious days inside the uterus are very important to us as far as the fetal survival is concerned. I always tell of my patients, 1 day inside uterus is equal to 2 days outside in the NICU. So if I can prolong the pregnancy by 5 to 7 days, I can cut the NICU stay by about 10 to 15 days, and that would make a world of a difference, especially in a preterm fetus. Suppose the Doppler comes abnormal at about 28 weeks or 29 weeks, and if I do an NST, if NST is normal, we can still prolong the pregnancy. Are there any other things which we can tell our pregnant females to look whether they can do by themselves? Fetal movement count. I'll make a separate video on this fetal movements, but we call it as a daily fetal movement count. We always tell the females to keep a chart of fetal movement count, especially after 33, 34 weeks. A fetus, normally, there are various methods of fetal movement count. What we do is fetal movement counting to 10. In a normal case, within 2 to 3 hours, there is a fetal movement count up to 10. And if that thing is there, that means the fetus is normal. That fetal movement count not only tells us about the intact neurological status, the muscular skeletal status, and the fetal heart. Because baby is inside a bag, in bag there is a water. If there is a good water and baby is getting good oxygen supply, baby's CV, cardiovascular system, neurological system and musculoskeletal system is intact, then baby would move both the hands and the legs. And if baby is moving both hands and legs, the fetal movement are good. That is a surrogate signal to the mother and thereby to us that everything is well. In a huge country like us, where there are scanty resources, not every female can get a Doppler and a NST done every time. Fetal movement count is very important surrogate marker for the wellness of the baby, and that is why we insist in every female that you keep a chart of the fetal movement count. However, many studies have been done. Some people say that this is good, this is effective. Some people say this is not effective. It is a better test. I personally believe that every female should have a fetal movement count, but after 34 weeks. Before 34 weeks, fetal movement count does not have any significance. Now, when does this NST and Doppler surveillance start? When do we start? See, at 12-13 weeks, we do an NT scan. At 23, 24, 25 weeks, we do an anomaly 3D, 4D scan. In high-risk pregnancies in which we know that there is going to be a fetal growth restriction, there is going to be a severe preeclampsia, which we can predict from a 12 weeks NT scan. In those cases, we start doing fetal surveillance from 26, 27 weeks onwards. We repeat survey. If that 26, 27 weeks Doppler is normal, maybe we repeat every 2 to 3 weeks. But NST is not done before 32 weeks, because if we do NST before 32 weeks, the fetus is immature and premature. Because of prematurity, the NST may not give us the desired or the good results. If NST is normal, then maybe we repeat it every weekly or twice weekly. If NST is not abnormal, we go for a Doppler. If Doppler is normal, then maybe we can do a frequent monitoring of NST. But if Doppler is also coming out to be abnormal, then maybe at what level of Doppler is, that we will discuss in the next, at what level of abnormality the Doppler is. In next series of videos, we will discuss whether to terminate the pregnancy or not. Like I said, NST before 32 weeks has got its limitations. We do not do NST before 32 weeks. NST in twins pregnancy is also a matter of debate. As far as I am concerned, I do not do NST in twins pregnancy. I just rely on the results of Doppler alone. In conclusion, whenever your doctor has asked you to come for NST, please go after a full stomach, at least an hour after a full stomach, because when you eat, after you eat, your blood glucose rises at least an hour after that, and that because from you, the maternal circulation, the fetal circulation, the blood glucose would be high and fetus may have got good energy. If both your Doppler and NST is normal, that means you do not have to worry an aorta. But these things can only detect from the chronic complications. An acute complication like a rupture of a vasa previa blood vessel or a abruption, they cannot predict those things. If there is an abnormal Doppler at full term, 34, 35, 36 weeks, and the NST is reactive, that means we can still pull on few precious days. Again, I am repeating, the Doppler parameters are abnormal and NST is reactive. We can pull on the pregnancies for a few days, 15 days to be precise. From the abnormalities of Doppler to a non-reactive NST, we still have got a 15-day interval. The only thing is, during that time, we have to do an intensive monitoring. We have to do a more intensive monitoring during that time. In conclusion, I would like to say not only the high-risk pregnancies, but every pregnancy, we should be doing NST at least weekly. If Doppler is a costly affair, Doppler costs about 1800, 2000 rupees, NST hardly costs 500, 600 rupees. If a patient is having, a female is having a reactive NST, I as an obstetrician and patient as a parent can sleep well that nothing is going to happen to the baby. Everybody should get an NST done in last month of pregnancy at least weekly. Hope you like the video. Please direct DM your questions and any queries you have. Thank you. Subscribe to our channel. Bye-bye.